specialist from Bournemouth in the UK, and this is my colleague Robert Middleton, who's a consultant orthopaedic surgeon from Bournemouth in the UK. What we're hoping to do is just sort of give you a flavour of enhanced recovery and its application in an orthopaedic setting. And now I'm aware that we've probably got a mixed group here, so we're just going to ask a few questions and get you to raise your hands at the start just to understand who we're speaking to. For those of you that are familiar with enhanced recovery, have used enhanced recovery in your hospitals and where you work, would you mind raising your hand for us now? Okay, good. And on the other end of the spectrum, those who are new to enhanced recovery, never heard of it before, don't know what it's about. So we've got a few as well. Also, professionally wise, doctors, hands up, please. Okay, and surgeons of those doctors? Anaesthetists? Managers, administrators? Nurses? Allied health professionals, physios, OTs, radiographers? A couple? Apologies if I've missed you out. But it's really important that we've got all those professions in the room because enhanced recovery is a team game. It doesn't work with just one profession. It needs you to work across your different disciplines and different professions. Enhanced Recovery's had a bit of a theme throughout the conference. Who attended the mini course yesterday afternoon? That's good. So some of you. What we've done, we've changed things around to make sure that we don't replicate the content in that session yesterday, but we're not going to sort of start from cold. So yesterday's mini course focused on general surgery. We're going to talk about its application in orthopaedics. At this point, I'm going to hand over to Rob Middleton. I've got the easy bit today, just doing the sort of setting the context and introductions. Rob Middleton is a consultant orthopaedic surgeon from the Royal Bournemouth Hospital. He is Director of Trauma Surgery at Poole Hospital, which is a neighbouring hospital nearby to Bournemouth. He's previously been clinical lead for the NHS Institute for Innovation Improvement for hip and knee joint replacement. He's a full-time clinician, full-time surgeon, but he also has a passion for quality improvement, and I'm looking forward to hearing him share his experiences with us today. Over to you, Rob.
Thank you very much, Tom. So we've got a packed afternoon. We've just got an hour, and what I'm going to do is, I'm not going to go into the actual detail. We run it normally, the detail as a one-day workshop, but what we're going to try and do is give an overview and to show what differences you can make to your healthcare systems. First, we need to introduce Henrik Kellett. He's really the godfather of enhanced recovery, as Sir John Charnley was for hip replacements in the world. And Henrik has revolutionised things because up until now, our treatment of patients has been unchanged. I'm a third-generation doctor, and my grandfather was a surgical houseman in the 1920s. My father in the 1950s and myself in the 1980s. And we treated patients exactly the same in a traditional manner. So, for example, the general surgical example, because Henrik is a general surgeon, patients with a colorectal tumour would be admitted 2 or 3 days before the operation. They would be starved and dehydrated. They would be given enemas and laxatives. And then they would have massive surgery under general anaesthetic, midline incisions, and afterwards they would be dripped and sucked and given opiates. So they came in physiologically well. After 2 days of starvation and laxatives, they were physiologically unwell. We then performed massive traumatic surgery, and then we treated them unphysiologically at the end. And they became very sick and unwell, and our job as housemen, my grandfather, my father and myself, was to go around and listen. When we heard bowel sounds, we allowed them sips of water. When they passed wind, we allowed them to eat. And that was often at about 7 to 10 days. And then a few of those patients, their anastomosis broke down. And Henrik Kellett revolutionised that because he said, what is the evidence for each one of those steps? And in fact, in most of those steps, there was no evidence. And he tried doing it completely differently. He brought the patients in the day of surgery. He allowed them to eat and drink. He didn't starve them. He actually encouraged them to drink within 2 hours of the operation. Minimally invasive surgery was used. Regional techniques and anaesthesia were used. And he got them eating and drinking immediately after the operation. And that actually protected the bowel that had been put together, because by eating and drinking, it stimulates the blood supply and the mucosa of the gut. and those patients recovered quicker, faster and better. And what Henrik says is enhanced recovery is evidence-based approach to care. It is designed to prepare patients for and reduce the total impact of surgery, helping them to recover more quickly. It is a multi-modal approach similar to that of care bundles. Now, at the time that Henrik was doing this work, a number of surgeons and others visited from the UK. And at the same time, we were doing similar things with rapid improvement programmes as well. Enhanced recovery is really now mandatory in the UK at the moment. All hospitals are meant to participate in it. And the Department of Health, if we just look at the bottom here, patients on enhanced recovery pathways recover more quickly following surgery and can so leave hospital and get back to normal activities sooner. It's better for the patient, but it's also better for our health communities. And what we're really talking about is altering this graph. Okay? So this is where you operate on the patient, they have a functional capacity decrease, and then they gradually return. And we want to shorten that period of time and also decrease the amplitude of it. So it's more like that. It's more like a blip in their normal activity. It is a multimodal process. You can't just pick out one area and work on. It's not just what happens intraoperatively, but each of these stages from referral all the way through to follow-up are important. And you can see all the different things that need to be optimised. It's a team game as well. This is not for one clinician or one manager or one therapist to do. You have to get it right at each stage, and that's why it's great today that we've got such a mixed audience. We need all those involved. So why is enhanced recovery important to orthopaedics? Well, there's the ongoing need and responsibility to improve quality and safety for our patients. There are changing expectations of our patients. They read about and they see other patients recovering more quickly. There are wider economic pressures. In many of our societies, we're having to reduce the cost of healthcare as our economies are in difficulty. And there are variations in outcomes coming under scrutiny. So our length of stay, our patient-reported outcome measures, within our own countries and regions within our countries, they vary. And the authorities are questioning why that is so. There are changes to the methods of commissioning of healthcare. There's competition, both private and state, and the changing demographics of our population. We're ageing, we're living longer, and therefore degenerative joint disease is more likely to affect us. So why is orthopaedics so important? If we look here at the list of the commonest elective operations in the UK, and that's the same for the Western world, we can see they come into groups of urology, gynecology, general surgery, and orthopaedics. But the key thing to see is the numbers. Orthopaedics is massive. If you look at one of these are just two procedures in orthopaedics, hip and knee replacement, but one of those is more than all the others put together. Okay? Primary hip replacement is the commonest elective operation in the Western world. If you do not solve that problem, you don't solve the healthcare problems. These are small numbers. Okay? These are huge numbers. If we look in a typical mixed hospital, and we look at all the subspecialties in surgery and medicine, and analyse them per spells, how many spells they have in that hospital, and the tariff or income they come, all the other subspecialties come in this area, and orthopaedics comes up here. Okay? Orthopaedics normally provides about 80% of the income or profit in a mixed hospital. Okay? It cross-subsidises all the others that make a loss or break even. It subsidises your ITU, your paediatrics, your social care and things like that. You cannot afford to get that wrong. Okay? It's important to get these right, but they make relatively little difference to the overall performance of the hospital. This is the elephant in the room, and this is what you need to concentrate on. Hospitals vary. Okay? What we're going to look at now is tariff per bed day. That's the amount of money each bed in your hospital makes. Okay? So if you turn that bed over more quickly, and you do more operations or treat other patients, you'll get more through. This is just for orthopaedics. And what I've done is I've taken the data from England, from all the hospitals in England along the bottom, and plotted the amount of money in orthopaedics they bring in for each orthopaedic day. And it varies hugely, doesn't it? The best performing trust gets almost £2,000 a day for each bed. Bottom performing, about 500. That makes a huge difference to the quality of care and how you run your hospital. I would like to be up here because I'm going to provide much better care, or have the opportunity to, than down here. So if the need for enhanced recovery is established, why aren't we all doing it? So what does the data tell us? And we're going to discuss the national survey. Okay. So if we look at length of stay, this is for knee replacement. Again, all the hospitals in England, and length of stay, and it varies from an average of 3 days right up here to about 11 days. Okay. So what are all the hospitals here going to say? They're going to say they've got a different case mix, aren't they? Their patients are different. They're harder, they're iller, they've got more social deprivation. So we need to case mix adjust those. So case mix adjusting involves taking all those factors, the age, the sex of the patient, the diagnosis, their medical comorbidities, their social comorbidities, about 25 things, and case mix adjusting it. And what it means is that you can then compare each hospital in the country, because their case mix adjusted should be naught. But that's not what we find. We find hospitals down here, for the same case mix adjusted patients, having a length of stay 2 days less than you'd expect. But at the other end of the scale, we got patients here staying 5 days longer than their case mix adjusted suggests. So let's put those two graphs together, and what we see is something very interesting, is that the hospitals here with the shortest length of stay are also providing the best quality of care. Because case mix adjusted, they're saving 2 days over what their case mix suggested should be. We would expect their length of stay to be up here if it's case mix adjusted. The other end of the scale, the ones here that were complaining that they've got a different case mix, that isn't the case. The reverse is the true, that their length of stay is up to 5 days longer than their case mix adjusted. So we have this split, don't we? We have these well-performing hospitals who are performing well above their case mix adjusted, and others that are performing below it. We talked about enhanced recovery and how it's really now mandatory. All hospitals in the UK are meant to do it. Tom and I, we write an editorial each year for Dr. Foster. Dr. Foster is an organisation that is half owned by the state and half owned as a private company. And it collects data from all our hospitals and produces an annual report in the UK. And that is for the hospitals, but it's also published. It's in the Sunday Times, our newspaper. And you can go in and rank the hospitals, see where they're good, where they fall down. And this year, Tom and I were asked to do the editorial, and we thought it would be quite interesting to look at enhanced recovery. And so what we thought we'd do is that we would ask all the hospitals 7 questions that we thought were critical to determine whether they were really doing enhanced recovery. Because if you asked them if they did enhanced recovery, they all said yes. And then we thought we'd correlate that with their results. Now, the results, if you've got a red arrow going up, that's bad. That means your length of stay is long. Okay? If you've got a green arrow going down, that's good. Your length of stay is less. So we asked them 7 questions. We asked them if they did preoperative education classes. 14 didn't. We asked if they admitted on the day of surgery. We asked if they had a standardised anaesthetic protocol. Did they have a multidisciplinary recording of patient records? Was there an orthopaedic physiotherapy service 7 days a week? Did they have a criteria-based discharge? And did they phone patients at 48 hours following discharge? So 7 simple things. But look what effect. A cross means that you don't do one or more of those 7 things. Okay? So where you see the crosses, you can see these hospitals had a longer length of stay. In this group where you see the ticks, you see in general a decrease in the length of stay. So there seems to be a direct correlation between actually implementing enhanced recovery and your length of stay. So we believe that enhanced recovery improves quality in every dimension of quality. And for that, we need to put ourselves up against international standards. And these are the 6 standards of quality in healthcare. Healthcare should be safe. It should be effective. It should be patient-centred. It should be timely. It should be efficient. And it should be equitable. So let's give you a case example. And I'm going to tell you about our hospital and why we needed to change. We needed to change because of our waiting times. Our patients were waiting a long time for treatment. We are having problems balancing demand and capacity. We had pressure to reduce costs. We had competition issues. And more importantly, there was a desire in the hospital to improve patient experience and clinical outcomes. The first thing you need to do when you want to bring about change in your own hospital is to analyse what you're doing. And if we looked in orthopaedics, we were doing about 150 procedures or so. Now, it's not practical to try and improve everything along that line. So we looked at the principle of what was the 80% we did. And 80% of what we did was just 12 procedures. So we did 6,000 procedures a year, but 12 of these made up 80% of the workload. And if we look more into that, hip and knee replacement was 25% of the workload. But the key thing is with the length of stay, it was 7.8 days. And a lot of work is done as day case or overnight stay. So 25% of our work was hip and knee replacement, but the majority of our beds were taken up by hip and knee replacements. So obviously that's the area we should concentrate on. Not that the other areas weren't important, but it's like that elephant in the room. In your hospital, you need to sort out orthopaedics. Within orthopaedics, you need to sort out hip and knee replacement. You can then use the lessons for the other procedures, but it creates the room allowing you to do it. The key thing that we saw that there were many pathways, that there was variation at every clinical step of the pathway. And variation is the critical thing in healthcare. That's where you lead to errors, you lead to this inequitable treatment of patients. And variation will be a theme that we'll see later. So what do? We analyse the issues, we assess the variability, both natural and artificial. We recognise what we could change and what we couldn't. You have to be practical. You can't change everything. There are some things, like people's contracts, you can't. And sometimes you just have to go round to a problem and come back to it. But it shouldn't stop you getting on with the change. We provided a framework which accounted for variability, and we kept it patient-centred. And that's very important. We had 2 rules of what we did. First, that we couldn't do anything if the only reason for doing it was that was the way we'd always done it. There had to be a practical reason why we did it. And the second, we couldn't do anything unless it had some form of patient benefit. It wasn't just for the doctors or the management of the hospital. And I think if you have those 2 principles, that can guide you through a change process. I don't know if many people know this. This is a chap called Dave Brailsford. He is the manager of British Cycling. He's also the manager of the Sky professional road racing team. And he transformed cycling in Britain to be the most successful cycling team in the world. At the last Olympics, Britain won more gold medals in cycling than all the other nations in the world put together. And he transformed it not because They had outstanding riders that were better than anyone else in the world. They had very good riders, but through this principle of aggregation of marginal gains, you can achieve optimal performance by the aggregation of marginal gains. It means finding a 1% margin for improvement in everything you do. And that's what it's really about. It's finding those small gains in everything we do and put them together. It's the reverse of when we have problems. When a disaster happens, or a death, or a never event, it's not normally one thing, but it's a lot of small things that go on. And success is exactly the same. You have to build up that bit of success. If you can be 3 or 4 or 5% better than your competitors, that's by how much you win. Okay? Usain Bolt is 3% better than his competitors in the last Olympics. Small differences make a huge change. And this is to emphasise that clinical pathways, and we're using hip and knee replacement example, are multi-step. There is no single magic step. Okay? Everyone wants that you give this anaesthetic or use this prosthesis or this drug or this exercise. On their own, they don't make a big difference in the overall package. You have to get that marginal gain in each step. So the question is, up until now, why have our solutions been failing? Why was the care that my grandfather provided very similar to the care that I provided? Why hadn't we seen so much change and improvement over 80 years as we've seen in the last 10? And that's because we were treating the symptoms of the problem, and the end result didn't change because we didn't change the whole system. Deming, many of you may know from the automotive industry, who helped restructure the car industry in Japan, said every system is perfectly designed to get the results that it gets. And unless you change the system, you're just going to get the same results being churned out. And that's what we've seen in healthcare. We've just got the same results, give or take a bit. So we need to change the system if we want to get different results. So the Deming system of profound knowledge, he said understanding variation is the important aspect when trying to understand a system. But how do we go about this in healthcare when so many factors vary from patient to patient? I said before, we focused on what we could change, not what we couldn't, but what we could change. Change needs to be non-confrontational. And the basic principle is standardise, do, study, act. Get a single pathway to reduce variation. If there's one message to go home with, and that is to get a single pathway. When we looked at hip replacement in my own unit, we had 8 or 9 different surgeons doing hip replacements, several of them doing them 2 or 3 different ways. Okay? One of those pathways must have been the better pathway. And you need to decide which one that is. Even if you couldn't choose on the best one, doing a good one is better than doing the best one if you all do it. You need to introduce daily and weekly outcome measures, and there needs to be ongoing audit and performance management. We talked earlier about making everything patient-centred, and that's very important because that's the reason we're here. It galvanises the professional groups. Whether you're a clinician or a manager, that is why you work in the health system. People forget that the accountants and things that work in our hospitals do so because they want to help patients. If it was for the money or for the perks or for the lifestyle, they would get a job in other industry or private industry where they're paid better and the conditions are better. They are as committed as we are to improving things, and that's why making it patient-centred is important. I'm going to say to you that the evidence base for orthopaedics isn't controversial. We actually know what we should be doing, but we're not doing it. And just to repeat, there is no single magic bullet. I thought there was. My mistake for the first 5 years of being a consultant was that I thought there was a magic bullet. I thought the magic bullet was minimally invasive hip surgery, that you could do a hip replacement through an incision that large. And I spent 5 years exploring that. I went to the States, I was trained up, I was a European trainer. I came to Paris on a number of occasions and trained surgeons in Paris how to do hips through incisions that size. There are reports of patients going home the same day, that this was going to revolutionise orthopaedics in our hospitals. But it didn't work out. There were incredible changes. I went to the States and I saw patients that did go home the same day. And I thought for 5 years that it was due to the size of the incision. What I came to realise that the incision size itself wasn't critical, but it was all the other things that had been done. Like Deming said, they got different results because they changed the system. They completely changed the pre-op, the anaesthetic, the post-op, the rehabilitation. And that was what's getting the change. And in fact, as the peer-reviewed journals came out over the next 5 years, it showed that there was no advantage of doing minimally invasive surgery. In fact, some of the approaches had significantly higher complication rates. And that operation, from being the next messiah coming, died and burned. But that's what gave me the understanding that it was the system, that it was the other things that the surgeons were doing to get their patients fitter and better that was important. So from that, I learned that there was no single magic bullet. We also focused on the clinical and process steps equally, doing the right thing right for every patient. As clinicians, we normally concentrate on this, doing the right things. And we get frustrated that it doesn't seem to change things. But equally as important is doing the things right. And this is where you need to marry up both the clinical and the managerial side. And that's why I work with Tom. We often present these workshops together and we do our clinical projects together because you need both. One on their own does not work. So getting the steps right. Okay. I said the evidence base for orthopaedics isn't controversial. We looked at all the evidence, and on most areas we have written reviews of the evidence which is now published, such as local anaesthetic infiltration for joint replacement surgery. What's its role in enhanced recovery? Most of the evidence is out there. There are reviews and other people's reviews, but you can get that evidence quite easily. You don't need to go away and do huge amounts of research and things. The evidence base is already there. We talked about variation, and there are two types. There's natural variation and artificial variation. Natural variation, it's like the people in the room. We're all different sizes and heights and weights and things, and there's nothing we can do about that. We can manage that, but we can't eliminate it. Artificial variation are the processes that we put in place in order to deliver our clinical care. And often those are artificial rules which we can remove. This shows the example of changing the therapy staffing in a unit. The first thing to say is that the scale on these two graphs is different. This is 250 up here, and it measures excess bed days. And that is days that patients spend in hospital greater than their case mix adjusted suggests. So if your case mix adjusted is 5 days for a hip replacement, you stay 6, you've got 1 extra bed day. And if you add that over the year, this is what you get. We put it per days of the week. So on a Friday, we have about just over 200 excess bed days, and on a Thursday, just under 200. We changed how therapy services were worked. This scale here is 50, so we're up at this level here, and you can see that all those bed days have been eliminated. And also, the scale's changed, but there's less difference between the days. So getting the process right and the system right allows you to standardise admission times and allows you a predictable theatre list. So we actually stagger the admission of our patients. This is an operation in a theatre, and we've got 6 there, one after the other, and they come in staggered. We actually have a sending list on there with times, so the patients are sent at certain times. Because our system is so predictable, we can do that, and it eliminates a lot of the waste. It also allows us to give things like energy drinks 2 hours before the operation, because we know when the patient is going to theatre. So successful implementation of enhanced recovery involves marginal gains to all the managerial and clinical processes across all departments, locations and professions. And it goes from pre-operative to intra-operative to post-operative and post-discharge. Clinical processes, yes, but managerial processes as well, delivering those clinical improvements. What I'm going to do now is that we're going to look at the results. I want to convince you that enhanced recovery does make a difference. All the results that I'm going to show you today have been published and peer-reviewed, and this is the journal here. All the slides that I'm showing you today are on the blog. They've been put up there, and you can see them there, and there are other tutorials and things as well. So this is all published evidence. The hospital looking at is my hospital, the Royal Bournemouth Hospital. It's on the south coast of England. We serve a population of just over 500,000. We've got 700 beds. It's the largest non-industrial conurbation in Europe, so there's no industry there. It relies on finance, leisure and retirement, and it's got an elderly population. And what we've got here is a run chart, an SPC chart, and we're just plotting sequentially the length of stay before our process change. So there's 400 patients before and 400 patients afterwards. There are two things to note. The second is the most important. The first thing is there is a step change in the length of stay from 7.8 immediately down to 4 days, which is maintained. So that's a reduction of length of stay by 50%. That is not the most important thing. The most important thing is the reduction in variation. So look before, that's the average, but look at the length of stay there. And I think you'll agree afterwards that variation is much less. That is the critical thing in managing our unit successfully. How can you manage a unit when you don't know if the patient's going to stay 3 days or 20 days? You can't manage your beds. It's impossible. On this system here, you can see we've narrowed it right down, and therefore it is much easier to predict your bed usage and your theatres. So let's benchmark our hospital before the change. Okay? So these are case mix adjusted. So all our patients are case mix adjusted in Dr. Foster with all the other hospitals in England. We've plotted all the hospitals in England down here, and they're case mixed age, sex, diagnosis, medical comorbidities, social comorbidities, all the others. And we all think we're better than average, but in fact, we're a bit below average. Our case mix adjusted suggested our length of stay was about a quarter to a half a day more than our case mix adjusted suggested. Okay? So we're just a little bit worse than average. We introduced the change, and immediately we came in the top 3 in the country. Our case mix adjusted immediately fell, so our patients were staying almost 2.5 days less than their case mix adjusted. Our length of stay had remained the same for years and years. And then with the change, it came down. So is that real? Is it cause and effect? Or is it just a statistical association? Well, let's look at it in more detail. Let's look at a QSUM chart. And these charts are where you can look to see whether the probability is this just by chance. Okay? So you plot the length of stay along the bottom. If you hit this blue line, this is the confidence line. If you hit that line, there's a 95% that your change was responsible for the improvement in the length of stay. So you can see we bumped along the bottom, we introduced the change, very rapidly we hit the 95% percentile and we continue to go up. That change was cause and effect. Okay? Let's look at it the other way. You can use QSUM chart for bad things like death rates, like MRSA rates. And that's how Dr. Foster in the north of England picked out a hospital with a higher death rate than expected. It had early warning that there was a problem because they looked at the death rate and it hit this blue line. In this case, we're looking at readmissions. It's fine if you overnight reduce the length of stay by 50%, But if they all end up coming back readmitted with complications or not coping, you haven't got forward. But what we can see here, 95% line, change, it just bumps along the bottom. There is no statistical correlation, and there was no increase in readmissions. So let's look more at detail. This was a department-wide change. We changed every process in the step. We're going to look at a prospective 2,300 patients. So every patient after the change, none missed or lost to follow-up. This was not a single surgeon or anaesthetist doing it. You can get guys who are superb and get results different from anyone else. Designer surgeons, we often see it with implants and things. But this was a group of 40-plus anaesthetists, 20-plus surgeons. And I'm going to show you that we reduced the length of stay. The readmission rate was unchanged. We had a low complication rate and a high patient satisfaction. So let's look at that first group of patients. 100% of the patients had their dates mutually agreed. This was a quality thing for the patients to choose when they had their operation. 90% attended our preoperative classes, and 100% of patients were admitted on the day of surgery. Whatever their ASA grade, whatever problem, we admitted them on the day of surgery. And 99% of patients waited less than 4 hours between walking through the door and having their operation. The average was about 2 hours 45 minutes. Another quality thing that the patients didn't like hanging around the hospital, but also an efficiency thing because we didn't want them being in the beds using up our ward space unless it was necessary. Early physiotherapy, on average, the first mobilisation after surgery was 7.5 hours. Clinical outcomes? Well, complication rates were at or below internationally accepted norms. None of our complication rates went up. They either remained the same or went down. We actually, in the first 1,000 patients, had a decrease in the patients readmitted. These patients genuinely seemed to be going home not only earlier, but fitter. We had extremely high patient satisfaction, and our length of stay dramatically decreased by 50%. So let's look at mortality rates. Well, mortality rates, 0.4%, fell to 0.04%. If you look at our 30-day mortality rate after the introduction of the pathway, it is 5 times lower than predicted for our case mix adjusted national averages. This is safer care. It's all very well having an efficient system, but patients don't want to be widgets in a factory being knocked out. So it's important not only to show that quality care is good and it's efficient, but what is the effect on our patients? And we monitored a number of ways. There are independent websites where patients can leave comments about their stay in hospitals, and there are patients who write into the hospital. We all hear about complaints and things, but we don't hear the other side. This is one of the comments on an independent website. If this is Orthopaedic's RBH style, congratulations. In what is a very difficult climate of targets and bed emptying, you've succeeded in remaining totally focused on your patients, and I, for one, are truly grateful. We monitored our letters. Before our change, about 5%, 1 in 20, patients would write in and thank the hospital, the nurse, the doctor, or the ward for their treatment. After the change, we had 30 to 40% of our patients were writing in. This was definitely an improvement in their experience. We also ran both our own local and national satisfaction scores, and they were all high as well. That's all very well, but if you're just rushing them through and putting the joints in, do they all fail later? Do they get poor results? Well, we're now mandated in the UK to do patient-reported outcome measure scores. These are done at 6 weeks and 1 year following surgery. They're national, so you can compare all the hospitals in the country. And this is a funnel plot. This is the number of joints you do. This is our hospital here, red. We're one of the, fourth in the country in terms of numbers. And what the funnel plot is, if you hit, the blue line is average. If you hit the level, the yellow line, that's the 95% line. That means that we've hit the line where our 1-year patient-reported outcome measures are in the top 5% in the country. So these patients were getting excellent function from their operations post-surgery. And the final thing is staff satisfaction. We have to maintain this. If this is a hellhole to work in, if we're tiring out our staff and they all leave, it is of no benefit. Our staff are motivated. The important thing is a team. We won a number of awards. The key thing is not that the anaesthetist and myself and Tom, but that we had a porter there. We had a nurse from the ward there. We had someone from the catering staff there, because it is a team effort to achieve this. In the UK, our staff in the NHS are nationally, in their payslips once a year, have a staff satisfaction survey, and those results are put together. There are a number of different ones, but this is just one, and we can compare hospitals across the country. So England is all the hospitals in England. The purple there is our hospital, and the cream is our orthopaedic or joint replacement unit. And if all our staff, and that goes from cleaner right up to clinical director, were asked, are you able to deliver the patient care that you aspire to? All our staff agreed or strongly agreed with that. And that was a very important quality measure for us. I talked earlier about my experience with minimally invasive surgery with single incision hip replacement. And that wasn't unique at the time. You'll hear about units that do day case hip replacements and things like that. But what you do, and I can teach any of you in the room to set up a unit like that. If you want to get in the papers or on the television, we can set that up probably in a fortnight. All you do is you cherry pick the patients. Okay? You pick young, fit people, say like Tom and myself. You educate them. You do the operation on a Tuesday morning at 7:30 with the best anaesthetist and everything there, and you can get most of those home that day or the next day. It is no big deal, because they're small numbers. Because if I had to earn my living from operating on people like myself, I would make my own money, because most of my patients are 75, 85 plus. The important thing about enhanced recovery is that it's for everyone. You do not do this on a select few. It'll work, but it won't have much effect. If we look at this chart here, we can look at the ages of the patients from 25 to 85. And we can see the expected length of stay, which is case mix adjusted, and the difference. And the negative means that we save days on all the patients. But the key thing is, the biggest benefit is for the 85 plus patients. Okay? So if you're 85, you're ASA grade 3, you've got poor social circumstances, you respond to enhanced recovery really, really well. Okay? If you're 25 to 34, we can knock 2 days off your stay, but we can knock almost 5 days off your stay if you're older. And this just displays it a different way. Enhanced recovery is for the elderly, ill patient. Okay? So if I was targeting a unit, and I wanted to have a short stay unit, I would target those patients, not the young ones, because they're probably going to do well anyway, whatever you do. Enhanced recovery benefits the ones with comorbidities the most. But what about productivity? We're now in economies, most of us here, that are shrinking, and our healthcare budgets. I'm clinical director at 2 hospitals, and we've been a target of reduce our costs by 15% over the next 3 years, and we've been reducing them by 5 to 7% for the last 3 years. How are we going to achieve that? Well, we're going to achieve that by decreasing our waiting times, by increasing our theatre capacity, by decreasing our bed capacity, decreasing our waiting list initiative work. That means not having to farm out work to the private sector or to other state hospitals that you can't do yourself. And we're going to have to treat a larger volume of patients. We've got an ageing population. So what did we achieve? Over the period after the change, our waiting times fell quite dramatically. Our theatre productivity increased. This is another run chart, and this is a single surgeon. He'd been working in the unit for over 10 years. He did about 100 joint replacements a year. And we changed nothing clinically about what he did. I said to him, I just want you to go to theatre and I want you to do the very best hip replacement that you can do. Okay. But I don't want you to worry about anything else. We will sort out the pre-admission, the anaesthetic, the setup of theatres, the implants and things like that. We just want you to do the surgery. And again, the key is not that there was a small drop in his operative time. There was a small drop for about 5-10 minutes. That wasn't the key thing. The key thing was the variation. Can you see how much variation there is? You think that's natural variation because sometimes he's got difficult patients, they're obese, or it was a difficult hip. But in reality, it's the artificial variation, the processes that we put in around him that were different. All we did was change the processes around for him. There was a small steps change in his length of operating, but that variation all went. That meant we could manage the theatres more efficiently. We never cancelled a case because we always got them done by the end of the list. Because we knew how long he was going to take to operate, our admissions clerk could pack more onto his list. In the year after the change, he did 120 joint replacements. Same surgeon, same time, but through reducing the cancellations and increasing the amount of his list, we got 20% more productivity out of him for no extra cost. Bed days, we were about 76 beds. We reduced our bed base by 16 beds. We just knocked another bed off, 17 beds off. If we look at the number of patients we've treated, started about 5,000. We've now got about 8,000 patient episodes, so our volume has gone up. And if we look at our tariff per bed day, we started off here, about £800 a bed day, and we ended up here with £1,600 a bed day. We were bringing in twice as much per each bed day. That allowed us to invest in our services and things. So we believe enhanced recovery improves quality in every dimension. So have we answered these questions? Well, I think we have. Safe. Our mortality rate is 5 times less than our case mix adjusted suggests with enhanced recovery. Is it effective? Well, yes. Our PROMS data at 1 year following surgery puts us in the top 5%. Is it patient-centred? Yes. The patients enjoy going through that. Is it timely? Well, our waiting times have gone down. Efficient? We're treating more patients. Equitable? Yes. The people who benefit most were the 85-year-old ASA grade 3s with comorbidities. The approach is not limited to hip and knee replacement. We started with hip and knee replacement because it was the elephant in the room. We applied the same techniques to our foot, ankle, shoulder surgery, and we're applying them to other areas. It also works in trauma. I'm clinical director of a separate trauma hospital in Poole. We've got one of the oldest age groups in the country. We do 1,000 fracture necks of femur a year. Okay? That's a huge number. Okay? We apply enhanced recovery. We do 1,000 fracture necks of femur. Our expected length of stay, case mix adjusted, national figures, up here, Dr. Foster. And if you look, as we introduced enhanced recovery, our length of stay has fallen. We're at about 11 days for our fracture necks of femur, compared with our case mix adjusted of 21 days. So we're at present saving 10 days per patient in 1,000 patients. Does that make a difference to our unit? Yes. Does it make a difference to the hospital? Yes. That is how we can improve our trauma service. So this is not limited to elective surgery. It is not limited to trauma surgery. It is better healthcare. So let's finish by saying it's the clinical decisions do the right things, but that is not enough. We need to do the things right. You need to join the two up to develop good patient care. Thank you very much.
Well, thank you, Rob. We've got about 5 minutes or so. Very happy to take questions. I've got a microphone here. I can run around if anyone wants to kick off.
My name's Penny Andrew. I'm from New Zealand. I was interested in, we started with this analogy to bundles of care. So within the Enhanced Recovery Program, are there sort of protocols or certain standard things that everyone should be doing internationally, orthopaedic teams, within like a bundle, within, say, a knee or a hip replacement? Or is there just a process that each unit should follow and develop its own bundle of care? Are there standardised things within a hip or a knee?
I think they're both. And certainly there are standardised things. So if we take fracture neck of femur, which we had last, NICE, National Institute of Clinical Excellence in the UK, and the British Orthopaedic Association, has come out with a standards of care for fracture neck of femur. So it is things like critical time surgery, 36 hours. So from breaking your hip to having your operation, it should be 36 hours or less, that you should be seen by a geriatrician within 72 hours. And there are a number of different markers there. So I think what you need to do is to use those as your basic thing. So there are certain things that you need to do. In elective care, it's similar. When I worked at the NHS Institute of Innovation and Improvement, they've looked at hip and knee pathways and other ones, and there's a lot of information on their web where they've, again, put the overall headings. What you need to do is to translate that into your own healthcare setting, because it varies from hospital to hospital. We have big teaching hospitals that are brand new. We have small cottage hospitals. But the principles are the same, but how you implement them will be different. We normally run sort of anaesthetic workshops and things like that. And one thing we emphasise is that we use a particular anaesthetic technique and things like that. It's not the actual doses of the drug and things, because it will depend on the experience of your anaesthetist, the patient population, other factors. So you have to take the general principles and then work with the team that you've got to modify it. So if I gave you all our protocols, they probably wouldn't be appropriate for all your hospitals, but the general themes would be.
I think the anaesthetic is a good example. If you look at the literature in terms of what is the best anaesthetic for hip and knee replacement, there isn't any clear absolute consensus. What you can say by looking at units that are high performing is that they've standardised to one agreed approach across their clinicians. That has a knock-on effect because your anaesthetic and your analgesic pathway that you fit with that, and how the nurses, the therapy staff deliver that needs to be consistent. If it's consistent, you can then change one thing at a time and continually improve it. There's lots of information on NHS Improvement website, NHS Institute website, and also on the blog in terms of breaking down all of the process steps which you've just asked about. In an hour's session, we can't go into all the detail of every clinical step. One last question before we finish, or if not, we'll hang around for 5-10 minutes.
Hi, I'm just interested in how you managed to get your executive to agree to a gain-sharing program to reinvest your dollars back into your own unit.
I think that's a key point, that you have to have buy-in from your board. As I say, it's the clinical steps, but also the introducing them. So I think leadership is important. You normally need a clinician who's going to lead this. And I started off by going and doing a presentation to the board, a blue sky presentation, very similar to what I've done today, to show the execs and non-execs the importance of orthopaedics in their unit and in the country as a whole, and how one could improve things. I mean, if you just look at that fracture neck of femur, I mean, what we've done is that we've reduced our length of stay by 10 days for 1,000 patients and delivered better care. And that better care is cheaper as well. So it's giving that vision, and to get one of the executives, the chief executive or operations director, on your side. Because when you have meetings in your hospital to do it, there are always 1,000 reasons why you can't do something. But that doesn't mean that they're right. Sometimes you've just got to push it ahead. And there are doors that they can open that we can't open. So it's talking to them, often a blue skies thing, using some of that data to show how you could change things in your hospital makes a big difference. So you need to get one on your side. So I do quite a lot of hospital visits and sometimes just go into an organisation for days, sometimes a bit longer. But one of the things I insist on before I go into any hospital is at the start we have a meeting with the important people. So you need director of nursing, you need the representative anaesthetist, the surgeon, everyone, but there has to be the chief executive and another board level person there. And then we go and do a walk round. The first thing in the morning is that as a group we walk around the hospital to each of the areas in the hospital to see what's going on. Because often the executive board don't know what's going on. They think they do, but they don't know what's going on. And that changes things. And it maybe we were in an anaesthetic department somewhere and the anaesthetist wanted an area that they could pre-admit the patients to, so they didn't have to come out of the anaesthetic area and go down a ward half a mile to do that. And it was only by having the chief executive there and realising how important that was that we got change. Because he said, oh, well, we could just knock that wall down and incorporate that room into there. If we'd had to go through all the committees to get it done, it would have never have occurred or taken months. But the chief executive was there. He made a decision. He told the operations director to do it. So blue sky thinking's a good way to start off.
Okay, I think we're sort of out of time. Thank you for your attention today. Any questions or queries, you can always get in touch with us via the blog. Thank you.
Thank you.